Good morning, everybody. I'm so happy to join good conference. Then today I will give 4 lectures and then 1 live surgical demonstration. My first lecture that is shortening and lengthening of nose. You know, in the past, most filters are using silicone and then insert fine. But now should make beautiful teeth is the key point of rhinoplasty. In order to make beautiful nose, the teeth longer and shorter is very important. And I'll show you how to make it longer and how to make it shorter. You know, it is short. Oh. It's a shortening of nose. The shortening. It's also shortening. That is a lengthening, longer, make it longer. It's also make it longer. Maybe many Vietnamese, they have a flat and short nose, then higher and longer. But in case of longer, not just longer, also should make it wide. A nose is very small, then longer and wider. Okay, then shortening of nose, we can separate, we can say hanging columella correction, arrow tip correction, hanging ala correction, and then how about the lengthening, short nose, retracted columella, retracted ala, that kind of thing. This we can separate. I will say separate. You have to know, to understand the longer and shorter, you have to know columella ala relationship. From the nether seal to soft triangle, the line B. In the center, there is A and C. It's the same, it's normal. But C is longer, in that case, hanging columella. And then A is longer, retracted ala. And then it goes, this is hanging ala, and then retracted columella. Then how about the shortening of nose? There are 3 things: hanging columella, shortening, and then arrow tip shortening, hanging ala, shortening. Hanging columella, it's longer, columella longer, how to correct. So there are so many techniques that as you can see, caudal septal resection of the medial crus, membranous septal resection, tongue and groove technique, cephalic rotation. Okay. It's a cephalic resection. Also, we can make a shortening of nose. You see, in this case, not too serious. Then just caudal septal resection here. Then can make there. Just say. Then in this case, I cut almost 7 millimeter caudal septal resection. Then finally can make shortening the columella. Then how about the caudal resection of medial crus? Your medial crus is here, but the effect is very small. Then only a little bit hanging columella. In that case, you can cut the caudal resection of medial crus. Then, how about the membranous septal resection? You know, after caudal septal resection and the membranous septal resection together. In that case, you can also make a shortening columella. She came from Canada. She had a big nose. Then I cut the cover septum here, almost 1 centimeter. And then membranous septal dissection, I did. And then decrease the position because her nose is too high, then should make her lower. Then decrease the projection, I did. Cover middle cross cut and overlap stitch will make her lower. Then finally, like that. But I think most Vietnamese nose is not too longer. But anyway, it's possible somebody who can have a very long nose. In that case, she is also saying, after operation, it's simply, my nose is still too young. In that case, you can remove membranous septal dissection. Usually membranous septal area. But even though you can remove cauda septum, it's also okay. Okay, and then already I said cauda septal dissection, dissection of medial crus of caudal part, and then membranous septal dissection, and then tongue and groove technique is also strong technique. Tongue and groove means after membranous septal dissection, and then lower lateral cartilage, medial crus of lower cartilage, and the caudal septum stitched together. It's a medial crus of lower cartilage and septum stitched together will make a strong shortening. It's very strong technique. But it's a strategy because lower cartilage should move, but in this case, cannot move. A little strange, but anyway, we can make it shorten. Cephalic rotation. Cephalic rotation means it's a lateral crus. The medial crus and lateral crus. Lateral crus cut and overlap stitch will make shortening of teeth. This lateral crus cut and stitch will make shortening. But she, after 6 months later, first time she preached about the result. But 6 months later, my nose is still long. Then I did membranous septum and the caudal septum and then nasal spine removed. Then it's a caudal septum, membranous septum, nasal spine. Then finally, like that, it shows breathe. The lateral crus, the lateral crus, cut and overlap stitch will make it shorter. Shortening of the column. But it's somebody like this, Middle Asian, from Middle Asian country, they have a really long nose. In that case, not just one technique, several techniques together. We see the cephalic dissection and then caudal septal dissection. And then nasal spine removed, nasal spine, and then membranous septal dissection, membranous septal dissection, and then nasal tip surgery here, and then her nose is very big, then nasal crus overlap stitch, to make it lower. And then also her nose is bulbous, too much bulbous. Then inside fat remove. And then after make smaller, the cut skin is too big, then it's cut skin here. Too much skin. Then skin cut. And then elevate surgery together. Then finally make it smaller. And then after operation, you have to fix like this. She also had a very long nose, and then caudal-septal resection, and then cephalic rotation, and then fix like this. And then how about the second? It's a correction of arrow nose. The hanging columella, arrow nose, it's the same technique, but hanging columella is middle part of columella, but arrow tip is the upper part of columella. The nether tip, too much longer. Arrow tip, you know, the arrow. And as I said, it's a different position, same technique, different position. It's upper part. Then it's cut here, membrane septal resection. Of course, there's caudal septal resection together. Then we can make it shorter. It's like this. She has a long nose. Then caudal septal resection, and then cephalic rotation. The lateral pleural cutting and the overlap stitch will make it shorter. You know, in case of female, too long nose, it's really not so good. It's look older, and then it's not beautiful. She's also some long nose to make it shorter. She's also. And then how about the hanging columella, hanging ala correction, number 3, hanging ala. There is ala mucosal resection, caudal ala rim, and then ala groove resection. There are three techniques. But you know, many hanging ala, somebody who come to a clinic and then they say, my ala is too long. But mostly they have a retracted columella. Retracted columella and hanging ala, it looks like similar. But the treatment is different. In case of retracted columella, in that case you should make longer, columella longer. After columella longer, it should look normal. Then you have to see, and then you have to choose correctly. Anyway, you can use the ala mucosal resection here. Just mucosal resection and stitch. But in this technique, not much effective, almost no effect, not effective. But anyway, small effect maybe. Cut here and then stitch. It's only a little effect, small shortening. The idea is to cut here and then shorten. But after operation, not too much effective. As you can see, not too much effective. That is, the second method is caudal rim resection. Caudal rim resection means cut here, cut here. If you cut and then stitch it, will make higher. But in that case, there is a low surface, no skin area. Then cut the skin from here to here. Cut the skin from here to here. Skin graft here. You can cut. It's the same, it's one side longer. Then cut here, and then cut, and then the skin from here to here. In this case, it's a restricted columella case. mild to moderate case, you can use this method. Because if you cut too much, the Allah shape is straight. You know the disadvantage of this method, because skin graft, then sometimes there is a scar problem. Then you have to explain before operation. The other way. The other way, you can cut here and then go up. It's very effective. Then, if you wanna do strong effect, like this cut, it's possible. It's like this, cut, go up, and then the skin from here to here. In my book, there is the video, whole video, same video. Okay, it's the same, that kind of operation, it's the same. And same technique, it's the same. In our operation. Oh, okay, then I'll talk about the lengthening of nose. Shortening, I already talked, and then the next step, that is lengthening of nose. Maybe most Vietnamese, they have a short nose, there is more needed, I think. The lengthening of nose is retracted columnar lengthening, retracted alar lengthening, whole alar lengthening, and then short nose correction, and foreshortened nose correction. To my books, I wrote, and so many books. Correction of retracted columella, that is from mild case to serious case. Caudal septal extension graft. If they have a strong septal cartilage, just one piece septal, even though one piece septal cartilage, you can attach here and then make longer. And then it's also saying it's a cartilage, you can make longer like this. Just the columnar lengthening. Then I reported first time about the contracting nose. Contracting nose. If they have enough septal cartilage in that case, you can use it's like X graft, like this. One caudal septal resection, caudal extension graft, one extension graft together. You can make it longer. And then, how about the retracted alar fraction? Retracted alar fraction. You can use composite graft. Composite graft, they are inside composite graft, outside composite graft, and then edge, the margin composite graft. The composite graft, there is skin and cartilage from ear, and then it's cut here and then move from here to here. you can make longer. It's like this, cut the cartilage and skin together, move, cut, attach here. Yeah, then also. But it's sometimes it looks like scar. It's you can see. Then when you give a comfort graft, maybe 6 months later, if somebody can see the scar and complain, maybe 6 months later, they need small scar correction. You have to say beforehand. It's better. It's comfort graft saying there is a cartilage and skin here, then move here to this. Then you can correct the nose tissue correction. But it's good, look good, but there's a scar. In this case, maybe 6 months later, there's some cut, the scar is better. And then also you can use not inside, outside margin, you can attach. You know, so serious indentation of the alar retraction, in that case, sometimes I attach here. It's more effective, but the problem is scar. And in this case, you have to say 6 months later, maybe you need scar correction. Yeah. But I think it's 70%, 80% is negligible. Scar is okay. After I don't know, before my clinic, she had a surgery and then there is a necrosis. Then in that case, inside composite graft is not much effective. And in that case, outside margin composite graft you have to do. And then you can give outside graft also here. You know, in case of composite graft, there is a two side scar like this sometimes, and then recipient scar. It's like this. Then composite graft, it's sometimes there is a scar problem. Then the second is just skin graft is also it's helpful, but compared to composite graft, not much effective. But my case, you can use just skin graft also, it's helpful. It's normal, it's like this, but retracted alar case is like this. Then you have to here skin graft or composite graft. Here skin graft is attached here. Or in case of deep cavity, cut skin cut here and then skin graft here. And then it's a projection graft. It's in my article in the PRS. Projection graft is not like composite graft. It's just this strong skin projection, like this. Strong skin cartilage projection. Yeah, in this case, we do projection graft here, and then here is making a pocket and the insert. After ESG and septal extension graft, extended spread graft and septal extension graft. Then after that is for projection graft. Here, projection graft. Stitching. Projection graft. One is septal cartilage, one is ear cartilage. And then making of pocket here. Making pocket here. And then can be make a long here, like this. Long. As you can see, this part is long. The same after to use septal cartilage, then septal graph and then F graph and the projection graph here. The projection graph. To use septal cartilage, yeah, it's a little longer. Yeah, please see the longer. Yesterday I learned how to edit video. This projection graph, the we cannot use in serious case. Sometimes composite graph and then projection graph together. One side projection graph, one side okay, just one side projection graph here. It's incorrect. Lateral pleural strut. In case of Caucasian, they use a lot. It's like lateral pleural strut. It's a dissect lower cartilage, and then sometimes there is a strut here, lateral pleural strut, and then it's moved from inside to outside, and then insert. But hey, in Asian people, the lower cartilage is very weak. It's not too much effective, I think. And then, serious case, how to correct ulnar retraction. In fact, ulnar rotation flap is the most effective technique. Cut and rotation flap. But in that case, maybe it's scar problem. Then the serious case, you have to explain. Yeah, it's ulnar rotation flap most effective, but it possibly scar problem. It's okay. Then patient accept. In that case, you can cut. But almost no scar. Don't worry. It's cut. Cut in the rotation, ulnar rotation flap. It's my icon. It's my icon. Yeah, cut, then rotation flap. Again, combined surgery is more effective. Ulnar rotation flap and projection graph together is more effective. So you can, as you can see, it's almost hard to do scar. Then skin projection graph with ulnar rotation flap together. You know the skin graph here and then projection graph together. You can use combined surgery. And then lengthening of whole Allah. You know, as you can see, this part Allah is smaller than the right side. Left side Allah is smaller than the right side. Then, in that case, Shiso technique, type 1. You cut here and composite graph and the projection graph together. Then you pull. You know, VY advancement, VY advancement is the same. Upper part cut, lower part cut, and pull down. It's the same. It's a checking how much longer and how much longer, and then cut, and then composite graph or projection graph here, and then longer, make it longer. And then Shiso technique is my article, and then Shiso technique type 1, so that's longer. But Shiso technique type 3 is one is longer, one is shorter. You know Shiso, Chaochaoban, in the elementary school student, they use Shiso. And then the one side longer, one side shorter. So Shiso type 1 is just longer. Shiso type 2 just shorter. But Shiso type 3, one side longer, one side shorter. And this part is longer, this part is shorter. Then this part cut, and then cut, and then pull, and make it longer. This part is shortened, like a hanging argument, columnar correction, shortened. And then the skin from here to here, skin up here. Then you can correct. This part is shorter, this part longer. Projection graph, the composite graph together. It's a dual step. Sometimes it may be there is a problem. In the case you dual step together. The number 4, short note correction. It's like Asian country, they have flat and short notes. And in this case, higher and longer. Then for lengthening, first you have to give a mucosal lengthening, and then skin lengthening, and then strong support. That is very important. Then mucosal lengthening usually cut the upper and lower cartilage. Then you can separate and then can make longer. The cartilage is not lengthened, but after upper cartilage, lower cartilage cutting, then you can make it longer. Yeah, and then sometimes it's because of scalp contraction, it cannot make longer. In that case, you can use composite graft or skin graft between upper and lower cartilage. And then also you can use low columnar dissection. You can make it longer. Yeah? It's cut can make it longer. Then we can make it skin lengthening. And then cartilage support, unilateral extended spread graft, bilateral X graft. You can use extended spread graft for the lengthening of short nodes. In this case, it's one side unilateral ESG and the strap. And then it's the same. In case of contracting node, you have to give a strong support, strong. Lock technique, that is like this. It's like this. It's my article. Cut. Cut. And cut. Okay. Oh, it's too long. And then bilateral septal extension graph is like this. It's a bilateral extension graph. Then X graph is my article. You can use also X graph. X graph is also ESG, and then it's like a septal extension graph. It's type 1, 2, 3. The X graph. You know somebody who has only a little college, in that case, X graph is more useful. Even though just the year of college, you can use usually college in case of contracting load. And then in case of no septum, also you can use. It's a type 2, it's a type 3. Just one side in your coverage, in that case you can use. So one, like this. But if it, in case of contact noise, you cannot use. But you know, in this case, the septum is intact. In that case, you can use it. And then one shield rod or that kind of thing you can use. It's also X graph, extended spread graph, outer septal extension graph, take a longer. And then also I-tail graph. It's like this. And then insert. In this case, outer septum is intact. In that case, you can use. It's also very strong. And then foreshortened nodes. But in case of foreshortened nodes, I will say after this lecture, I will briefly say like this. Foreshortened nodes, contracting node case. Okay. And then how about after my second lecture, if you have a question or comment, I will. Okay, it's okay. My second lecture, that is